Hello? 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 Yeah, I am audible. Okay. So, for the functional examination of the elbow joint, for the functional examination of the joint, we have some passive tests also. So first, I told you that we have first of all we will go for our passive flexion, then we will go our passive extension, and we have passive pronation, and we have passive supination, right? So, if so first of all, when we are going to check our passive flexion, we are getting here soft hand feel. We are finding the soft hand feel. Otherwise, we will find the other muscle approximation will be there. Next, when we will go our passive extension, then we will come our hard hand feel. We will find out there is a hard hand feel. We will find if it is a hard hand feel, then it is okay. Then if we are going to passive pronation, for the passive pronation, what we will do, I will just hold her patient's wrist and I will just take one thumb and I one hand passive um, pronated position. So in the pronated, oh, Network issue. छोड़ मैं मनदीप मैं इसको जस्ट verbally करता हूँ. Okay. So for the passive extension, we have seen passive pronation. In the passive pronation, we are coming over the soft end feel. We are finding the soft end feel there. If it is soft end feel, then it is okay. Passive supination, we will also find here is also soft end feel. In the passive supination, both hands soft end feel will be there, right? One important part is that when you are doing the passive pronation, in the passive pronation, what happens? There is a biceps muscle. It has the two heads. One head is directly insert in the radial tuberosity, and our second head is comes our bicipital aponeurosis. So bicipital aponeurosis is something like this is the structure of the okay. So there are the structure something I will get here the bicipital aponeurosis. There is the radial tuberosity is there. So we have here short head is there, we have there long head is there. So if there when we are when we are doing the passive pronation, what is happening? Our short head of the biceps is going to compress between our radial and ulnar joint. So in the passive pronation, if there is a pain at the biceps, tenoperiosteal junction of the biceps, then it means then we have the tendinitis of the biceps muscles, right? So in the four tests, we we have done passive flexion, extension, pronation, and supination. So by doing these tests, we will know that is there any problem of the joints or is there any problem of our contractile structure. If these four tests are okay, then we think our contractile structure. If these tests are not okay, then we think that this is the problem of our joint capsule, right? And the joint capsule, if we are going to discuss about the joint capsule, now what can be the things happen in the joint capsule, right? So for the joint capsule, we have few things. Okay. So in that we have know that it is the capsular pattern. It is if the anything is wrong, then the patient will be in the capsular pattern. Okay. If these all four tests will be normal, then it is a non-contact, non-capsular pattern. Yeah, it is something that the problem of our muscle. It may be the problem of nerves. It may be problem of the outside the joints. Okay. Whatever the structure is outside the joint, we will assess that part another way. Whatever the structure inside the so in the passive test, we will assess the structure which is inside the joint. Right. In that time, we have clear our passive functional test. Now, what can be the possibility happen in the capsular pattern? Capsular pattern means if the person just fall down on the outstretched hand, he just hit our hit his her elbow. What will be happen? Just after the injury, there will be the traumatic inflammatory changes will be there. So that will go. That will patient will go our traumatic now after and word traumatic arthritis. What happen in traumatic arthritis? There will be the swelling will be there because there is a severe muscle spasm that will be there. And after that, what we will do? We will just take the patient, just do for sitting for 3 to 4 weeks. Just take the complete rest. Traumatic arthritis patient we will easily find out. Traumatic arthritis, what will be happen if the patient traumatic arthritis patient will unable we can if we will do the passive flexion will not be complete. If we do the passive extension will not be complete in the acute stage. But it is if the patient goes to advanced stage, what will be happen? Passive pronation and passive supination, both movements are also restricted if it is the advanced stage in traumatic arthritis. Done. Now the second thing we have the fracture of head of the radius. So head of the radius, we have the head of the radius. This is the head of the radius. It is the structure which is just like in this line. So if what happen if if the child yeah, any person suddenly hold the arm, what will be happen? Sometime it the head of the radius is just come outside of the annular ligament. Annular ligament is just, it's like this is the covering of the annular ligament. This is the bone, and inside the bone, over the bone, there is the one ligament which stabilize the radial head of the radius. Sometimes there is an injury, there is a fall, there is a outstretched hand, there is a pull. So there is some fracture happens in the head of the radius. Head of the radius fracture also accompanied with supracondylar fracture of the patient. Say that history of the patient is that he is having supracondylar fracture, as well as sometimes patient is also having the head of the radius. Sometimes if the patient is getting the problem in the head of the radius, then what will be happen? If there is a head of the radius injury, then we can easily do the passive flexion. We can easily do passive extension, but when we will do the passive pronation and passive supination, the pain will be there. There will not be, will be the restriction of the passive supination and passive pronation, because the supination and pronation is only the movement of the head of the radius. It is not the movement of the elbow joint. Going to is to anywhere, if he is doing the forceful extension, if we are doing the forceful extension, well, again, there will be the bleeding will be inside the joint, and once the bleeding will be inside the joint, myositis oxidation, new bony nucleus can develop, and then bony nucleus can develop inside the joint. Bony nucleus and bony nucleus can develop. There is a one muscle we call it brachialis muscle. So brachialis is start from the lower side of anterior and anterior lateral. So it covered from to this area. So this is the brachioradialis brachialis muscle. So sometimes the myositis ossification newborn formation start below the brachialis muscle. Once patient once the myositis ossification start, what will be happen? There will be the development of the and bone underneath the brachialis. And when the patient come to our clinic, there will be a form that will be like that will become tight. If there is now this is the soft, but if the newborn formation the muscle within the muscles, that is very tight structure. That is we can easily palpate. For the myositis ossification, the only treatment is this: we just take the patient for 3 to 4 weeks. We can just take it. We have the patient for 4 weeks. If in the 3 to 4 weeks there is a spontaneous revolution, sometimes it automatically stop processing, and sometimes it is if it is a completely consolidation, bone formation is complete, then what we will do for our orthoscopic excision. Once the orthoscopic excision will be done, our myositis ossified, our new ossified bone will be taken off, and then we orthosis. Orthosis happens. You must have seen the patient of old age patients. In the old age patient, what happens? Patient the number and it goes to cervical spine, and it goes to our acromioclavicular joint, our annual. With the joint articular surfaces will be start. There will be degeneration of joint articular surfaces, but in the rheumatoid arthritis, our joint capsule will be affected. Hence, if you will just palpate the head of the radius, you will feel there if you are doing the passive pronation and supination, and if you are doing elbow flexion and extension, you will feel there is a synovial thickening. Joint, there will be the joint laxity will be there. You will feel the temperature. You can see that the temperature will be rise. Synovial thickening will be there. You will feel that the joint is completely thickened. So these are all the features of our rheumatoid arthritis. In the patient of the rheumatoid arthritis, patient also give history of the metabolic things, and patient sometimes also gives a history of the weight loss and other things. So the patient of osteoarthritis and patient of rheumatoid arthritis, you can easily find out whether it is the osteoarthritis or it is a rheumatoid arthritis. After that, if you want, you can go for medical imaging. For the medical imaging, if you will go the osteoarthritis, we will find some osteophyte formation, we will find and joint stiffness. But in rheumatoid arthritis, we will find that articular surfaces, articular margins are okay, but joint laxity in the joint capsule. After that, one more thing we are going over the ankylosing spondylitis. Ankylosing spondylitis is totally different thing. In ankylosing spondylitis, what will be happen? In ankylosing spondylitis, there will be the fibrosis of the joint capsule. There will be the more stiffness than rheumatoid arthritis and osteoarthritis. Ankylosing always spondylitis always start from our sacroiliac joint, then it goes our hip joints, then it covers our lumbar spine, cervical spine, this spine, and after that it start to develop. It start from distant to proximal. It always start from distant to proximal. It don't happen that spondylitis start from neck. It always start from down, and then after the 4, 5 years, 10 years, patient say that I have the bamboo spine. I am not able to move my neck. Okay, so patient start that there is acromioclavicular joint that will develop, and then it will also lead to elbow joints. So in ankylosing spondylitis, there will be the complete fibrosis. So inability to flex and extend our arms. Now we have these are the things which we check by the passive functional test. So these the things can happen in the patients if we find anything, but sometimes it gives the symptoms of the capsular pattern. So for the non-capsular pattern, we have first of all we have the sprain of our radio ulnar joint. If suppose patient is fall down and he is patient is getting the sprain over the radio ulnar joint, what will be happen if there is a sprain of the radio ulnar joint? It will also cover our joint capsule because our joint capsule is covered up to the coronoid coronoid fossa up to the coronoid fossa, and here is the coronoid process. So it will cover complete our joint. So if there is a pain sprain over the radio ulnar joint, then you will also feel that we are when we are doing the passive pronation. If passive pronation, when you will do the passive pronation, you will feel the pain over here. So we can think that it can be also the passive sprain of our radio ulnar joint. Sprain of the radio ulnar joint will go our annular ligament. Annular ligament is just like it's a ring. So it's a ring. So when the ring is just holding something, it's like this way. It is like this way. So you're just holding your radiant to ulna, right? After that, we have loose body, one or more fragments. Loose body is this patient is coming in our clinic and he is saying, yesterday night I was okay, but tomorrow, yeah, day after tomorrow, what happened? My elbow is stuck. Elbow range is 135 up to here, but what will be happen? Patient is elbow will stuck somewhere here. Okay, it will not go from this place. So you will when you will press, you will take it forcefully. There will be the springy end feel. You will take the force, it will go down. When you will leave the force, it will go back. Right? Sometimes it happens if the extension you are trying to make it straight, but when you are leaving, what will happen? It will again go to the flexion position. It means there is some loose body which is going to stuck between the joint. If it is stuck between the joints, you can see that is this is the joint line. If something will be stuck inside the joint, what will be happen? That will prevent our normal movements. So we will get some incomplete movements. As I told you earlier, then capsular pattern, what will be happen? Flexion will be restricted. Extension will be complete. But loose body, there is a extension will be limited, less flexion will be limited. Understand? Again, I am repeating it. In the loose body, extension will be more limited than flexion. Okay. Sometimes it happens that flexion range of motion is complete, but in the extension range of motion is not complete. You must have seen the physiotherapist. The patient is coming and physiotherapist is looking okay. I will just do it. And after that, what is happening? He is just giving the fully force in the elbow joint. So what is happening? That may also create our capsular damage because something is inside that is not going to help him. So we have the two procedure to remove that thing. We have the orthoscopic movement. Otherwise, we have our joint manipulation technique. Joint manipulation technique I will come to in the treatment part. Right. After that, loose body is the thing which depends upon age to age. If the patient is the articular cartilage, the bone will be die. The bone will die, and after that, what will be happen? The die bone will just exfoliate from this place, and that die bone will just move, and after that, that will try to come inside the joint structure. Okay, and if the patient is the adult patient, for the adult patient, what will be happen? All the adult patient is mostly having the history of injury. Mostly patient is having the adult patient is having the history of road traffic accident. Okay, so road traffic accident is very common in that, and they just patient just fall on the outer surgeon and they just stuck their elbow, and once they just stuck the elbow, mostly they just hit the elbow to the ground, and when they are ground, there will be the traumatic arthritis will be there. There will be the hard swelling will be there. There will be the severe muscle spasm will be there, and after that, till that time, some loose body may be stuck inside the joint. That can be also be our cartilaginous loose body, right? And we have the third category of also. The third category is old age patient. Old age patient, suppose we have the patient of 60 years, we have the patient of 70 years. That patient can also develop loose body inside our joint capsule. How does that thing will be there? If the patient is developing severely osteoarthritis, severely osteoarthritis in the joint capsule, there will be so many we can say osteophyte formation will be there. Sometimes that osteophytic part will develop and will stuck inside the joint capsule. So we have here three types of loose body. One loose body is we have the adolescents. Second we have the adult, and third category we have the old age patients. So the treatment part is also different of every patient. So if the patient is coming the endo, for the endo patient have the part is the bony nucleus. So for the bony nucleus, if the patient is young, then the part then we have to remove it by the orthoscopic procedure. If we will not going to remove that in orthoscopic, body is something that structure like this. What there will happen? That will come between the joints, and there uh, to cut our own other indigenous layer. Suppose we have the layer of this. We have the layer of articular cartilage like this. Our loose body is coming here. This is a bony nucleus. This is a active bony nucleus. If it is active bony nucleus, we are doing regularly movements from day to night. We are just moving our hand. What will be happen? Elbow joint is a free joint. It is not a weight bearing joint. It will be this bony nucleus. Sometime it may go right and sometime it may go left. It cannot be happen in a one particular place. So what will be happen? There is a soft cartilage will be there. If then one nucleus sometime is here, then it will rupture the cartilage. If moves from here, it will rupture of the cartilage of this place. If it goes to here, that will rupture of the cartilage of this place. So in the patient of osteochondritis dissecans, our optic bony nucleus will try to rupture our articular cartilage. So we will go for our orthoscopic excision. Right. If the patient is coming in the adult traumatic arthritis, what will happen in the traumatic arthritis? There is a trauma, but our articular cartilage is may also be damaged. So in the traumatic arthritis, the loose body can be the articular cartilaginous part. If there is the articular cartilaginous part, what will be happen? We will just go for medical imaging. We will just check on the X-ray. If in the X-ray we do not show any loose body inside our in the X-ray, then we will think about this is the cartilaginous loose body, because the cartilage we cannot show in the X-ray. Cartilage cannot come will be come in the X-ray, but even after our hand is going to stuck, it means that it is the cartilaginous loose body. Then if it is cartilaginous fluid body, we can just go for manipulation technique and we can just make it completely okay. Then we can go for our cartilaginous manipulation technique for our cartilaginous loose body. But if our loose body is going to visible in the X-ray, if the in the X-ray, if we just go side the anteronatal yeah, anterior view, if the loose body is visible in X-ray, then it means this is the bony nucleus, active bony nucleus. If this is active bony nucleus, then we will go our manipulation techniques. Though that will not making of help. If the if loose body is visible in X-ray, then we have to go for our arthroscopic managed procedure. Third category is this: if the old age patient is coming, osteoarthritis there is a severe osteoarthritis. Osteoarthritis, what will be happen in osteoarthritis? There is a complete degeneration of the articular surfaces. Articular cartilage is just above the articular surfaces. So after some time, what will be happen? The articular cartilage will try to exfoliate from this place, that place, and that will come inside our joint capsule. So loose body. So in the arthroscopic old age patient, we can go for our joint manipulation procedure, right? After that, we have our we have completed here our passive functional test examination. Now we are going our contractile structure. For the contractile structure, we have for the contractile structure, we have certain muscles are there. Okay, so for the muscles, we have here we are just going to focus here. We are going to focus our contractile structure, or we can we are going our structure here. So for the non-capsular structure, we have our biceps brachii. We have the two parts of the biceps brachii. It has short head. It arises from the corporate process and it directly goes our radiant tuberosity. So it is goes like something like this: coracoid process to radiant tuberosity, and we have the long head which start from the supraglenoid tubercle of the humerus, and it directly come like it develop bicipital aponeurosis. So in that condition, what will be happen? There is the biceps brachii is the main flexor of the forearm, right? And we have few muscles also which is also going to flex our elbow joint. So one of the muscle we have the brachialis muscle which is just below the upper and lower border. And you just make it resisted elbow flexion. Do yes, 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 yes. So this is the resisted elbow flexion. If our biceps muscle over the biceps of the biceps muscle, sometimes pain happens in the main muscle belly. Okay? Sometimes pain happens for the muscle. There is, there is the muscle belly. This is the muscle belly, and after that there is the tendon. So this is the tendon of the muscle, and tendon goes to like this. So this is our tenoperiosteal junction of the bicipital biceps brachii. So one, two, three. We will have the pain in three locations. So, if the patient is having pain in the musculotendinous junction, we will go to treat over this part. If the patient is having the pain of the musculotendinous, then we will treat this part. And if the patient is having the pain in the tenoperiosteal junction, then we will try to treat of this part. Okay? Okay. So, uh, so we have done here the resisted elbow flexion. Resisted elbow flexion, we will get the pain. After the functional examination, the important part is this: you have to go for palpation techniques. Once you will go to palpation technique, in the functional examination, you come to know that pain is in the biceps. But when you will go to palpation technique, then you will know that which part of the bicep. Now I am going over brachialis muscle. Brachialis muscle is the but the brachialis muscle work when our elbow is in the complete pronation, right? So I have done here complete pronation, and in the complete pronation, I am doing elbow flexion. Do assisted elbow flexion. Yes, 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 yes. So in this position, if we are doing the elbow flexion with elbow pronated is our brachial assisted elbow flexion, we will think if the pain is coming, then we can think that it is a muscle of our brachialis muscles, right? Brachialis muscle is very wonderful muscle. It gives our something 60% strength of our elbow joints. Okay, and it is also important part. When our hand reach up to this level, you will get the power from the biceps brachii. Okay. Next, we have the third muscle. We have the third muscle of the brachialis, and then you are making resisted elbow flexion. Yes. So flexion, this muscle. Okay. So we have tested here the. Huh? We don't know. Okay. Are they restarting video? Okay. So we have covered here the our biceps brachii. We have covered our brachialis and we have covered our brachioradialis. For the brachioradialis, we will go in the mid prone position, assisted onward flexion. In the mid prone position, In the front position elbow flexion, we will get our main work will start over the brachioradialis muscles. So, break for the brachioradialis, we have the brachioradialis in this region. So for the brachioradialis, we have to check in the mid front position. Okay. Again, after that, we are going to focus about our as a resisted elbow extension. So as we know that in the resisted elbow extension, we have the two muscles are there. We have the strong muscles of the triceps. Okay, and then we have the small muscles that is here that is the anconius. Anconius and the triceps brachii is the muscles of the our elbow extension muscles. So our anconius is a very small muscle. For the anconius muscle start from our the olecranon process of the humerus, and it will directly goes out over the radius. So it will start anconius will start over this part, and that will go over this part. So the anconus will insert over the lateral surface of the shaft of the radius. Right. So we have here three. We have the triceps here, and we have the anconus here. Triceps is also having three heads. So for the triceps, we have the three heads. One is the long head is there. We have the lateral head is there. We have the medial head is there. So these three heads will work at different in the system. If we suppose if the patient is coming and we are doing our resisted elbow extension, in the assisted elbow extension, if the pain is coming, then we can think our affected muscle will be triceps or anconius. Anconius muscle is not get tendinitis so common. Triceps is the very common muscle which get over the develop tendinous pain. In the triceps, we can also think about of the we can think about the muscle, and we can also think about our the periosteal junction, right? So the important part is this: if there is a three muscles of the triceps, how will we know that our which segment is affected? Maybe the medial part, maybe the lateral part, maybe the long head will be there. So we have the one test for checking our triceps muscles. So what will be happen if the patient is coming? Then we will just say the patient in the slightly relaxed position. Just take it extension. Just take it complete extension. Just go for complete extension. Sometime if the patient is supine, we just kept our hand straight, and then we are saying the patient just press my hand, and if the patient is pressing your hand, then there is the complete extension is going to happen, but the main work is doing our long head of the triceps muscle. Second, if the patient is saying, I am not getting the pain, yeah, even he is saying that I am not getting too much pain in this position, but I am still getting some pain over this triceps region, then we can think that maybe the lateral part will be affected, maybe there is the medial part will be affected. Then what will we do? If the medial part will be there, then if in the supine position, then we will say the patient supine position, just lie down, hold it. Just lie down, and we will take the hand in 90-degree position. In the 90-degree position, we will say the patient just go for elbow extension. Elbow extension, patient is doing elbow extension, and if the patient is getting pain, so it may be the pain of our triceps medial part. Now we have the third thing is there that maybe the patient can also have the pain in the lateral head of triceps muscle. So, head of the triceps muscle, we will just take it slightly abducted. Okay, so we have taken the humerus slightly abducted. In the slightly abducted position, we are just going slightly laterally, and then we are going elbow extension. Just elbow extension. Assisted elbow extension. Patient may have pain over the lateral side of the triceps. So for the Long head we have in the Newton position extension, slightly Newton. For the median head, we will just go the median. For the lateral head, we will just go slightly abducted position. These are the three things which help us to know about our triceps muscle. So triceps tendinitis is very common for the players, for racket, badminton, hockey, the person who is doing very vigorous activity. Triceps is our main muscles, which are also very concentric muscle of the elbow joint for the elbow flexion, elbow extension. Triceps is also working with elbow flexion as a eccentric muscles. Suppose when we are doing push-ups, what is happening? Triceps is also working. That is going to stabilize our body. You think like when you do just push-up in the midway position, the triceps is just stabilizing. This is just going you down, but the triceps is just trying to take you up. So these will work over the eccentrically when we are going to down, and in the push-up when we are going to up, then it is the main concentric muscles. Now, in the time we have completed our brachialis muscles, we have completed our biceps muscle, we have completed our both hands of the biceps, and we have also covered our three heads of the triceps muscles. Now we are coming little bit down from here. So a little bit down from here, we have the flexor compartment and we have the extensor compartment. We talk about our flexor compartment. In the flexor compartment, there is the eight muscles are there. Okay. So first muscle we have the pronator teres muscle, we have flexor carpi radialis muscle, we have palmaris longus muscle, we have flexor carpi annualis muscle, and we have the flexor digitorum superficialis muscle. And then we have the three deep muscles. These five are the superficial muscle, and these three are the deep muscle. So for the deep muscle, we have flexor digitorum profundus, we have flexor pollicis longus, and we have the pronator quadratus. These are the deep muscles which make our flexor compartment. Flexor our compartment start from our medial epicondyle, and it directly goes our wrist joints. Seven deep superficial muscles, and we have five deep muscles. So the superficial muscles, as I already told you, we have the anconeus muscles, we have the brachioradialis, we have the extensor carpi radialis longus. That we have here our brachialis muscle, anconeus muscle. Anconeus muscle is going to start from lateral epicondyle, lateral just lateral epicondyle is just going to finish over the lateral shaft of the radius. And then we have the brachioradialis. Brachioradialis when we yeah, lateral brachioradialis will start just over the lateral epicondyle. It will you will find here just upper impression of the you will find here there is the tubercle will be there. So this is the lateral epicondyle and this is the ridge. So it is the humerus ridge, and upper impression of humerus ridge you will find here extensor carpi radialis longus muscle that is going to inside over our extensor carpi radialis longus is over the base of the base of the second and third. It is going to insert over the wrist joints. Okay, so we have anconeus, we have brachioradialis, we have extensor carpi radialis longus. We have here the muscle of the head of the radius, even lateral epicondyle. We have the extensor carpi radialis brevis, and these are the four muscles. And after that, we have the extensor carpi annualis, and after that, we have the extensor carpi annualis, and after that, we have the extensor digiti minimi, and then we have the extensor digitorum, extensor digitorum. These are the seven muscles which comes from lateral epicondyle and that insert our ribs and gives the supply of our extension of the proximal and distal phalanx. We have the five deep muscles are there. So five deep muscles we have the supinator, we have abductor pollicis longus, we have extensor pollicis longus, we have extensor pollicis brevis, we have extensor pollicis longus and extensor pollicis brevis, as well as we have the extensor indicis. So these are the five muscles. Total we have the seven superficial muscle of the extensor compartment, and we have the five deep muscles of the extensor compartment. So now, what is happening here? So we have just discussed about these are the muscles. Now we have done here resisted elbow flexion. We have done here resisted elbow extension. Now we are thinking about our resisted supination. If the patient, we will take the patient hand in the mid prone position, and we are coming our resisted. We have just hold the wrist. If we will not hold, we don't want any movement in the wrist joint and shoulder movements. So we just stabilize her elbow mid prone position. We just fix it wrist, and then we are taking the patient in the supination corner. Just go for assisted supination. Assisted supination. In the assisted supination, what is happening? In the assisted supination, two muscles are working. So first muscle is the supinator, and second muscle is the biceps brachii. But resisted biceps brachii. But how will you know about which muscle is our affected muscle? Sometimes the patient may have also pain in the supinator, and sometimes patient may also have pain in the biceps brachii. So what will you do? If you will just do it supination and the pain is coming, then you will also go for our resisted elbow flexion, because the biceps brachii has both the function. The biceps brachii has elbow flexion, and biceps brachii has also elbow supination. If elbow supination and elbow flexion both tests are giving pain, both tests are positive, then the affected muscle is the biceps. If our only supination is giving the pain, it is only the muscle of the supinator muscle. Supinator muscle start from lateral epicondyle to the ulna. So it will help us to make it in the supinator position, right? And after that, we are thinking about our pronator muscles. For the pronator muscles, if we are doing the resisted elbow pronation, just go for resisted lateral elbow pronation. In the resisted elbow pronation, our main muscles are the pronator teres and pronator quadratus. Pronator teres is coming from our pronator teres is coming from the median epicondyle, and it is directly inserted uh, over our shaft of the radius. And we have the another muscle. We have the another muscle which we call is our pronator quadratus. Pronator quadratus start from the lower part of the radius, and it insert over the lower part of the ulna, and it insert over the radius, shaft of the radius, and sometimes it also cover over the interosseous membrane, the membrane which is inside the both the bones. Okay. So if we are doing the resisted pronation, just do the resisted pronation. In the resisted pronation, we can think about pronator teres or pronator quadratus. So once we have done our pronation, then we can go for our palpation method. So we will palpate and then palpate the muscle. So if there will be the tenderness will be there, then we can think that it is pronator teres or pronator quadratus. The important part is this: pronator teres is also originate from the median epicondyle, and the sometimes if we do the patients in the resisted wrist flexion, then also patient have the pain in the medial epicondyle. Okay? Okay. So in that position, you have to think about, if the pain is coming in the resisted wrist flexion and pain is coming here, and if the pain is coming over the resisted pronation, then the culprit muscle is the promoter teres muscle. If resisted flexion is painful, but resisted pronation is not painful, then it is not a pronator teres. It is the median bone for elbow. Yeah, it is the median flexor compartment. Median flexor epicondylitis. We will get. So we have completed here elbow flexion resisted, elbow extension, elbow supination, elbow pronation. Now we are going to makes our resisted wrist flexion and resisted wrist extension. So resisted flexion and resisted extension, we will just stabilize the patient's just hand stabilize, and we are just focusing over our resisted elbow, resisted wrist flexion. Just go for resisted wrist flexion. In the resisted wrist flexion, we are just going to focus over the medial epicondylitis because our flexor compartment is just originate from this medial epicondylitis. So we are thinking about the medial epicondylitis. Sometimes it happens that pain may be the tendinoperiosteal junction. Sometimes the pain may be in the musculotendinous junction. Right. If we are thinking about now, if we are doing the assisted wrist flexion with open finger, we have open our fingers. We have done open your finger. We have done the assisted wrist flexion. In the assisted wrist, resisted wrist extension. If we are getting pain in the resisted wrist extension, we are getting pain. It means the pain is coming our over extensor extensor compartment. So in the resisted wrist extension, we have the six extensor of the wrist. We have six wrist extensor. So first wrist extensor, we have the extensor carpi radialis longus. We have extensor carpi radialis longus and brevis. We have extensor digitorum. We have extensor digiti. We have extensor indicis. Okay, and we have extensor digital superficialis. So these are the six muscles which help us to make our resisted elbow, resisted wrist extension. Okay, so what is happening? We have done the resisted wrist extension, and resisted extension pain is coming over the extension. Yeah, pain is coming over the lateral epicondylitis. We can think that these are the six muscles which make our resisted wrist extension. But again, what will we do? We will just say the patient, just close your hand, just close your hand, and after that, when the patient is closing his or her hand, then we are going for our assisted wrist extension. Just make it extension. Now, for the resisted wrist extension, we have only the three muscles: extensor carpi radialis longus, extensor carpi radialis brevis, and extensor carpi ulnaris. These are the three muscles which make the wrist closed finger wrist extension muscles. So and the we find out that these are the three muscles are there: radialis longus, radialis brevis, and extensor carpi ulnaris. Now the question is this: how we find out that our extensor carpi ulnaris is giving the pronoun, or our extensor carpi radialis longus or brevis is giving the pronoun? So what we will do, we will say the patient just make it resisted wrist extension with radial deviation. Okay. So when the patient will take hand in the resisted wrist extension with radial deviations, so we can think that extensor carpi radialis longus and extensor carpi radialis brevis are the main muscles which have the work for resisted extension plus radial deviation. So we in this way we exclude our extensor carpi ulnaris. If we will do resisted extension with ulnar deviation, so we can think that this is the muscle of extensor carpi ulnaris. So once we find out then this is the extensor carpi ulnaris, we will clearly treat the extensor carpi ulnaris muscle. If we find out this is the extensor carpi radialis longus and brevis, what? How will we find out this is the extensor carpi radialis and longus and brevis? For treating the extensor carpi radialis and longus and brevis, extensor carpi radialis longus start from me. This is the lateral epicondyle. Just above the epicondyle, we have the extensor carpi radialis longus muscles. Okay, and we have the lateral epicondyle. Extensor carpi radialis brevis start from the lateral epicondyle. Extensor carpi radialis brevis start from this place, and extensor carpi radialis longus start from this place. So if we are thinking, we have done the resisted wrist extension with we have done radial deviation If the pain is coming, then we can think about of these two muscles. After these two muscles, what we have to do, we just go for our palpation methods. We will take the hand, patient hand in the same next position, mid-prone position, and we will just press. We find out the latent epicondyle. This is in the latent epicondyle. Just go little bit up. We found out this is the area of our extensor carpi radialis longus. So if we will palpate the patients this area, if when there will be this muscle will be affected, there will be a severe tenderness and pain will be there. Right. If our extensor carpi radialis brevis is affected, we will palpate our latent epicondyle. We will find the pain over this area. Right. So we excluded everything. We excluded our 7 plus 5 superficial and deep flexors. We excluded each and everyone. Then we just close the hand. There the three muscles are remaining. We have done longus and brevis. For the longus and brevis, we do for differentiation. We will just find we only know about the original insertion muscle and what is the action of the muscles. We will just hold the lateral epicondyle. We will go little bit up. We will find the longer and origin of the longus, and just middle epicondyle, lateral epicondyle. We will find the origin of the extensor carpi radialis brevis. Extensor carpi radialis brevis is the only the muscle which is the main powerful muscle of our wrist extensor muscle. This is only our agonist muscle. We can say that it is only our concentric muscles. And extensor carpi radialis longus is the synergetic muscle. It work with extensor carpi radialis brevis. It work with this brevis, but it is not the main muscle. The main muscle is the extensor carpi radialis brevis. This extensor carpi radialis longus support the brevis. So sometimes if the patient is coming in our clinic, he says, "Sir, I am getting the tennis elbow." Yeah, you say that you may be the tennis elbow. Tennis elbow patient have the pain may have the pain in 4 points. Patient may have the pain in the supracondylar ridge of the humerus. Okay, patient may have the pain over the lateral epicondyle. Patient may have the pain over the head of the radius because extensor carpi radialis brevis have the tendon over the over the radial head. Then it start from this place and then it develop over the musculotendinous junction, your main muscle. So tennis elbow patient say that I am getting the pain, but patient is confused. He don't know that where is the exact pain. He just tell that patient pain is the in the this area. But it is the duty of therapist how to find out which is the patient main pain pattern. A tennis elbow have the four types of pain. One type of this tennis elbow it is the supracondylar ridge of the humerus. Then second we have the lateral epicondyle. The lateral epicondyle we have the second point. Then we will just go little bit in the supracondylar area. We will find here this is her head of radius. So head of radius we find here, and we have the fourth vein is there. We have the musculotendinous junction. So patients always give the four types of pain for the tennis elbow patients. If we have done the resisted wrist extension, if the pain is coming over the lateral side, then it is the patient of the tennis elbow. So the important part of the tennis elbow is this. Tennis elbow is four types. So how to differentiate and how to find which muscle is ever working, which muscle is affected, or which is not. So we will find out tennis elbow point one. We have tennis elbow here. We will find out type 3 tennis elbow here, and we will find out type 4 tennis elbow here. In the patient, when the patient comes in our clinic, he is so confused, he even don't know. And sometimes it happens the patient of type 1 tennis elbow plus type 2 tennis elbow may have the together. Patient may have the pain in the type 1 and type 2. Sometimes it happens that patient give the pain. Patient don't have the pain over the extensor carpi radialis longus. Patient have pain over the extensor carpi radialis brevis or tenoperiosteal junction plus body of tendon. So it happens. It is the type 2 tennis elbow and type 3 tennis elbow. Right. So at the time of treatment, at the time of diagnosis, you have to differentiate which type of tennis elbow is this. Suppose the patient is coming of the tennis elbow type 2, and you are giving the ultrasonic, you are giving IFT, whatever the treatment you are giving in the type 1 tennis elbow. Will it affect? It will not affect. So If you clearly know that it is a type 2 tennis elbow, if it is a type 3 tennis elbow, you can easily locate the position, you can easily locate the palpation method. So you can give your treatment directly over that tendon. You are not supposed to give the treatment over the vigorously. It is not like this, we are tennis elbow there and we are giving the treatment over the complete lateral side. We are just find the tendons and then we are giving the treatment over that particular tendons, right? So if the extensor carpi ulnaris, sometimes extensor carpi ulnaris, or जो also originate from the lateral epicondyle, right? But that is also giving the over the lateral side. But it happens that if extensor carpi radial is longus and extensor carpi radialis brevis is not affected, extensor carpi ulnaris is affected, and you are treating the patient as you are thinking about it is the case of the tennis elbow. So you have to go for our extensor carpi ulnaris. And right now, I am also going to finish the treatment protocol of the tennis elbow. For the treatment protocol of the tennis elbow, if we have the patient of type tennis elbow, so if it is type 1, then we will go our deep transfer flexion massage, then we will take the position in the elbow supination, sorry, elbow supination and elbow 90-degree position. This is our elbow 90-degree and this is elbow supination position. We will just take our nail off and we will find out our this is the lateral epicondyle. We just find out over the lateral supracondylar ridge. Here we find out this is the extensor carpi radialis longus. So what we will do, we will just take the hand, we will take, and this is my nails are there, but when you will do in your clinic, just take your nail off and you will just take the reserve of the skin up, and then you just take of reserve of the skin up, and then you just take it downward. You will just take it downward. So you can see that I am doing. This is a completely arm movement. You can see this is a arm movement. I am not doing anything from my thumb. I am just doing my arm movement. If I will do just this thing, my thumb, what will be happen after some time? The arthritis will develop also over my metacarpophalangeal joint, yeah, proximal, this thumb joints. And after 1 and 2 patient, I will be fatigued. I will not, my body will not allow to take me 4 5 patient. So what will I do? I just keep the hand. I will take the reserve of skin upward and I will just do this movements. So what is happening? I am just doing my shoulder movements, and the shoulder movements I am doing type 1 tennis elbow DTFM. She is not a patient of the tennis elbow. If she had the patient of the tennis elbow, once I am doing, she can start the crying because it is not easy methods. And if once you just do it 15 to 20 minutes. If you are doing this procedure 15 to 20 minutes, then you will know that after the 20 minutes you will start numbing effect. After 10 to 15 minutes, you will feel that when you initially hold it like that was the another thing, but after 10 to 15 minutes, if you are doing it properly, you will feel that there is a start of numbing effect will be there. Patient is saying that I am getting benefit. After just 10 to 15 minutes, he will say that "Sir, at least I am 40% okay with only one session. Okay. So I have the name here, otherwise I can do it properly. Okay. So now if you are coming of the type 2 tennis elbow. In the type 2 tennis elbow, what is happening now? Like neither type 2 tennis elbow, what we will do, we will take the hand in the same position, 90-degree elbow flexion, it is in the supinated position. We will just take the lateral epicondyle, and you think that muscle position is just like this. Muscle is just like this. It is originate from here and it is going to here, and we are going to the deep transfer friction massage over the this point. So what we are doing, we have done the lateral epicondyle, we have the taken reserve of skin inside, and they are looking outside. We can keep here our slightly cotton piece. So when we will keep our slightly cotton piece, we are not going to hurt the patient. So we are just going outside, we are just going inside, we are just going outside. You just feel, you are getting feeling. So this is the Extensor carpi radialis brevis muscle. If it is the originate and it is the tenoperiosteum tendinitis, then you have to do that. You have to release the tendon, and after 10 to 15 minutes, you will get the effect. Hence, you get the numbing effect after one session. Patient at least say that I am the 40% over. Okay. Then we have the type 3 tennis elbow. Type 3 tennis elbow is over the radian head. We find out here the radian head. In the type 3 tennis elbow, we will take it in the third, three, fourth position. In the type 1 and type 2, we have to make it 90. But in the type 3 tennis elbow, we make it 75. We just make it is three-fourth of the elbow flexion, and we are taking it in the pronated position. I have done it in the complete pronated position, and then I am going the radian head. I have the palpate the radian head. I am taking reserve of skin medially, and then I am coming laterally. You can see that if I am standing here and in the wait, wait. In the standing, you can see how easily this tennis elbow may be for physiotherapist. Yeah, I have just taken her up. And now for the type 3 tennis elbow, we just palpate head of the radius, and once palpate head of the radius, we make it in the pronated position, third, fourth of the elbow flexion. We are taking our hand in this position, and we just hold the hand, and then we are just going reserve of skin taking inside, and then we are coming outside. We have taken reserve of skin inside. So this is one active phase and one passive phase. Suppose it is the depend on the therapist. If somebody want to make it lateral side in active phase, he can make the lateral side. If I want, I have taken reserve of skin medially, and then I can make it active phase in the lateral side. I have taken reserve of skin lateral side, and I can make the active phase in the medial side. So it is the depend on the therapist what side he is comfortable for. He can make it medial or he can make it lateral side. The important part is that the hand position will be third fourth of the flexion, and it should be the pronator. You first raise the head of the radius, and your hand, your thumb, it should be straight. Okay, and after once you are taken, then it is also the and shoulder movement. We are not doing wrist movement. We are not doing any our elbow movement. It is also the our shoulder movement. So we are going to complete our voluntary complete body movements are there. Sometimes we can move forward. Sometimes we can go backward. Okay. So now we have the type 4 tennis elbow. For type 4 tennis elbow, as we know that type 4 tennis elbow is a musculotendinous junction. This is the muscle value of type 4 tennis elbow. So for the type 4 tennis elbow, then we have to make a pinching grip. We just hold the hand, and we can make it reserve of skin outside, and then we are taking reserve of skin. Then we can make active phase in the inside. Then again we can take outside, and again we can take inside. So for the tennis elbow, we have कहानी है जितनी जगह है ये भी हो रही है right. So interpret start. So We have completed here tennis elbow complete four types: one, two, three, and four. So whenever the patient is coming in our clinic, we will first of all we will find out which type of tennis elbow is this. Treatment protocol may be different according to the therapist. Some therapists are very good in binding that can go. Some therapists are very good in cupping. Some therapists are very good in ultrasonic. Some patients, some therapists have the laser therapy. Okay. So it is the up to the therapist what the things, what quality he has. The treatment what protocol he or may she may have according to his or her knowledge, his or her experience, his or her expertise. Okay. Some if this patient come to me, this patient come to me. If this patient come to me, then I have the only the option. Then I will go deep TKFM. And one important part is this: I am going to teach you the means manipulation. There is the procedure. There is the procedure. In tennis elbow, we believe there is the relative avascularity is there. There is the adhesions. These are the tendons. You can think there is the 7 plus 5, 12 tendons are coming from this place. So sometimes there is the inflammation. Once there will be the inflammation, there will be the adhesions will be there. That adhesions will prevent for tendons of sliding. Tendons slide in our over the bones. So there will be the adhesions will be there. And you are giving the best treatment, but even because of the adhesions, tendon are not going to free. So what will happen? That time you have to go for our mesh manipulation. Then mesh manipulation, what we will do for the mesh manipulation, we have wonderful things. Mandeep, is it okay? For the means manipulation, we will take the patients in the okay. You just in this position, just go. Okay, just slightly. Yes. So we have means manipulation. In that means manipulation, what we will do, we will take the patient and we will take the patient abducted. Then we will take the patient completely median rotated. We have done complete median rotation. And in the median rotation, we have done hold the hand like this. This is my hand. This is her hand. I hold the hand, her hand like this, and I have done the complete wrist extension. Right. This hand is completely median rotated. Wrist completely extended. I am doing this. That I will do it perfectly. Then only we can release the adhesions, which is holding our intrarticular um, extensor carpi rotalis longus and brevis tendon. Then we are making. Then we are for means manipulation. We are just going one. Just relax. We are just going one, two, three. We are just doing the patient like this, like this, like this. We will give this procedure only one or two times. We can repeat this procedure in a week, at least two times in a week. And after that, this procedure is followed by our deep transfer friction massage. Over and before the massage, as we require, we can give the hot and cold therapy. We give two times in a waist manipulation and followed by 15 minutes of deep TFM. The important part is this complete median rotation, wrist flexion, wrist extension. We just hold the hand and we just make it one, two, three. Okay. Sometime there is the voice. Sometime you will feel there is a sudden cracking voice, and sometime not. If the voice is not coming, sometime it doesn't come. It is not means that you have done wrong. Sometimes it comes. Sometimes it comes very well, even very audible that everybody can listen. So if you are doing this, then it is also okay. And after that, important part is this: just do it and just do complete stretch exercises. You can start with the stretch. You are feeling the stretch over here. You are feeling stretch, and after that, once you have done the mesh manipulation, you have done cold and hot therapy, and you have done the deep transfer massage. Over the period of time, you start to giving. Once the patient is saying that I am getting an 80% patient, I am pain relief, you start to give the patient of eccentric consent eccentric exercises. For the eccentric exercises, what will I do? For the eccentric exercises, first of all, I will for the eccentric exercises, I will what will I do? I just take a I just take a theravance. Okay, just take the hold the theravance, just straight, make it straight. I just hold the theravance and I just take it like this. I will do it like this and I will hold it. When I will hold it, what will be happen? Our extensor muscle will try to hold it like this. Our flexor muscle is working, but extensor muscle is extensor muscle is eccentrically going to active. We will start exercises of the eccentric, then we will go our strengthening exercises as we will progress. Okay, so we have completed here up to the now we have completed tennis elbow complete. Now we are thinking if maybe one patient can become and there will be the weakness of the elbow flexion. If there will be the weakness of elbow flexion, what can be the positive factor? So if suppose patient is coming and he is getting weakness, so what you can think? If the patient is getting weakness of the elbow flexion, two things will be there. One thing will be there. There may be the rupture of the biceps muscle. That may be the partial rupture, or that may be the complete rupture of the biceps muscle. If you think that if it is the rupture of the biceps muscle, when you will do the resisted elbow flexion, you will get the bone type structure here. If it is the tear, if it is partial or complete tear of the, you will start, or sometimes it is the tear, you will passively elbow flexion, you will get here bone type structure. So you can think, yeah, you can know that it is the rupture of our biceps brachii. Second point is this. Second point, mein, what will be happen if elbow flexion will be weakness? It may be the neurogenic. It may be the neurogenic. So how will you check out it is the neurogenic? Then you will go for checking the myotomes and dermatomes level. For the myotomes level of checking the elbow flexions, then you have to go for elbow. We have the supply of hand C5, C6, C7, C8, and T1. Right. For checking of the C5, what we will do, we will just take the for C5, we will just simple. We will take the patient hand and we will press downward. Upward press. You just press up, and we are pressing it downward. We are pressing it downward. So this is the our humerus abduction. So humerus abduction and humerus lateral rotations comes gives the supply of C5. Next, we are coming over the C6. If the patient is having the cervical radiculopathy and he is having the herniated over the cervical spine, maybe there will be the root, there will be the C6 root affected. If the C6 root value is affected, what will be happen? C6 gives the supply of elbow flexion as well as wrist extension. So we will find out if the elbow flexion is weak as well as wrist extension is weak. Then we can think this is the lesion of our C6 lesion. But C6 lesion cannot happen alone. Cannot happen maybe wrist extension or may not wrist elbow flexion. So we have to conclude both the things. If it is C6 level affected, then our elbow flexion will be affected and our wrist extension will be affected. So these are the myotomes, so which we have for assessment of the root value. Suppose if we have the, we can think about C7. Patient comes to clinic and he is the radiculopathy and he is the herniation. He says, MRI say that he is the having C7 radiculopathy compression. So what will be happen for the C7 and radiculopathy compression? We will just check elbow extension. We will going to see the elbow extension and then we are going to see wrist flexion. So for C7, wrist flexion will be weak. Wrist flexion. Yes. Resisted wrist flexion will be weak. Elbow extension and resisted wrist flexion will be weak for C7. If the we have to check it earlier, and we find out that it is can be C8. Then for the C8, we will check our flexor policies numbers. Flexor policies number just supply over the C8. So for the C8, we will just go make it flex. Okay, so हो रहा है वो कौन आ गई थी. So we have just we finished that it is the system elbow flexion and wrist extension, C6 elbow extension and wrist flexion, 8 sorry C6 and C7 elbow extension and wrist flexion, C8 we will go for the flexor position numbers, and if we are going to try know about T1, then for the T1 we have the this and one we know the finger adduction things which helpful for our main diagnosis. If the patient is having a tendinopathy, if the nerve root is involved, then we can do this myotones test. We will know that which is the myotones level is affected. After that, we have the dermatomes level examination. For the dermatomes, we know that T6 is T6 is coming laterally and C7 is coming medially. T1 and T2 coming distally. So these are the our dermatomes level. And after that, one more thing we can do, we have our reflexes are there. Bicep reflex, and we have the triceps reflex are there. For the biceps reflex and triceps reflex, we can do with a simple manner. So for the biceps reflex, we can know that our reflex is weak, is it intact, weak, or exaggerated. So if there is a and like this, you can make it hand like this, and so this is the reflex pattern. So we just check our reflex. We just check the biceps reflex. In the biceps reflex, we are just doing small tapping, just doing small tapping, and we are getting the reflex. So we can know that our biceps is okay or there is a problem. So we have the another thing. We have the uh, triceps reflex. For the triceps reflex, we just take our hand and we just tap, है so we come to know that it is the reflex of the is okay or aggregated or weak. So so we have done the neurological examination as well as our contact and section. Now, if we are doing the resisted elbow extension, some patients comes for the olecranon fracture. When there will be the olecranon fracture will be there will be the weakness will be there. Patient will not allow us. Patient will unable to do complete elbow extension because of the fracture of our olecranon process. Right. The another part is that sometimes the patient comes and there is the olecranon bursitis are there. This is the medical imaging. This area is just inflamed. This is the olecranon bursitis. For the olecranon bursitis, there will be a pain as well as there will be no weakness, but there will be the limitation of movement. Patient there will be no weakness. Patient has the complete power, but there will be unable limitation of extension. Patient can do up to the here. Patient cannot make the complete elbow extension. So we have the following things with the resisted test. We can do these things and we can know that what is the diagnosis. And after that, if the resisted extension is weak, so one more thing can be happen. It may be radial nerve compression. So for the radial nerve compression, we can go for the when there will be the weakness of the radial nerve, what will happen? Resisted wrist elbow extension and as well as there will be the resisted wrist extension will be there. Okay, so we have completed this part and we have completed supernatural chapter. One more thing is there is one common cubital tunnel syndrome. Cubital tunnel syndrome means there is the olecranon process and we have the lateral epicondyle. Between the olecranon process and lateral epicondyle, ulnar nerve directly goes from this area. Sorry, sorry. So ulnar nerve come to this area. So this is our ulnar nerve compression happens. Some happens because the nerve is going to compress. So if the nerve is going to compress between olecranon process and medial epicondyle, it is the carpal tunnel, cubital tunnel syndrome. It happens. It happens more females because the females have the more cubitus valgus or varus angle in elbow as compared to men. So last part we have the golfer elbow. Golfer elbow is the corner of the cone flexor tendon. In the golfer elbow we have the main test of our resisted wrist flexion. Golfer elbow is also two type. It is a type 1 and type 2. Type 1 I already told you, Christian, and type 2 over the musculotendinous junction. For treatment of the part of the golfer elbow, what we will do, we will just go our fingers over the flexor compartment and in the supinated and complete extended position. Then we will take the hand like this, and then we will go our arm movement like this. Sometimes we can go like this. So we have the deep transfer fixation massage over the flexor tendinitis. So we can go for tenoperiosteal junction and we can go for our musculotendineous junction. So with these words, I am going to finish my webinar. I have just completed it as I can share as much as possible. And from my side, I shared my complete knowledge here. And thank you so much, organizer, and thank you so much all the Physio webinar team and giving me chance and sharing my views. Now, if you have any questions till now, my webinar, anyone can ask any questions. So please ask your questions. Any doubt you can clear any doubt from me.
Thank you. Thank you so very much, sir, for enlightening us with
Thank you.
such a wonderful. And I hope everyone here who have participated in this webinar have achieved and grasped something very good. So if you have any kind of queries, you can mention in the comment box or you can ask in the WhatsApp group. Thank you, sir, and thank you every attendees who have patiently listened to our honorable speaker. And once again, before winding our webinar, I would like to thank this Physio Webinar Club for organizing such a great webinar. And thank you so much, sir. Keep
Thank
learning
you, ma'am.
always. Thank you.
Okay. क्या हुआ? Finish?